Dr. Anupindi, thank you so much for joining us on MD Newsline podcast. Can you please introduce yourself to our audience?
And thank you for having me. I'm Dr. Aruna Anupindi. I'm a consultant clinical oncologist based at Churchill in Oxford. And my specialist interests are breast and urothelial carcinomas.
hmm Can you tell me a little bit about the patient population that you serve? What are their demographics generally?
Okay, so basically, I'm a clinical oncologist. That means I give chemotherapy and radiotherapy. So for the breast patients, I do chemotherapy as well as radiotherapy, and the prostate ones, mostly radiotherapy, and the urology in the bladder cancer ones, I treat with chemoradiotherapy. And they are middle class, middle socioeconomic status, and I actually work in a satellite center
Mm.
to Oxford, so it's not as affluent or academic as Oxford, but I do serve a big population compared to my Oxford colleagues.
hmm
Mm,
And have you seen any trends
mm.
as you've practiced over the years? I know that some people have spoken about kind of age changes in patients and things like that. What are some of the things that you've observed in the field?
Yeah, so basically, again, so recently, there's a big shift in prostate cancers. We do have screening programs for breast cancer, and there's no actual screening program for prostate cancers. But I think Chris Hoy is one of the celebrities in UK who's diagnosed with stage 4 prostate cancer. So there was a big, publicity thing. So even younger men around 50s,
Mhm.
when they go to the GP, they can get a PSA test and they're diagnosed pretty early on. So, I'm getting a lot of younger men because most of my patients are in their 70s.
Mm.
And now it's a shift is I'm seeing more younger men being diagnosed because it's just the awareness. People being more aware and nothing else has changed. It's
Mm.
just people being more aware.
Are there any common misconceptions that you come across even with this new emerging conversation about things like prostate cancer? What are some of the
Mhm.
misconceptions or questions that you might even get in your
Well, the
practice?
misconception is, I'm from a South Asian community. This is the big thing. I've been doing few talks locally because, as I said, we have screening programs for breast cancer, but the take up is quite low in the South Asian community and most minority communities. So I've been doing a few talks and saying, misconception is, oh, the cancer word is a taboo. We can't talk about it. And B, it doesn't affect me. And so I thought, I've been working with a few charities to actually get the word across and say, look, any cancer, the rule of thumb is if it is picked up early, it can be easily treated or cured. And then, nobody is invincible. So all of us should be aware because, you do find there is a big difference, huge difference. Most of the South Asian population, or for that matter, Afro-Caribbean population, it's just basically because I don't know if it is a cultural thing. They don't go for screening programs, and hence most of these people are present quite late. At the diagnosis, even though these are very early. It can be detected very early. The PSA, the prostate cancers and the breast cancer, you can see a lump and all that.
Mm.
But still, you do find symptomatic patients
Mm.
rather than screening patients.
Yeah.
So,
Have you seen any difference in approaches from the younger people that maybe come in versus the older people? And are they overlapping at all? Are
it does overlap, and you do find, there's always a trend that these younger patients, that's what we actually, there was a discussion in the topic just earlier on about younger patients with breast cancer, especially. They present with some odd biology. They actually have more aggressive disease. So we all, as oncologists, I think, if you ask any oncologist, I think most of the oncologists will tell you you're very, very careful about your young patients. You want to be a bit more aggressive because they tend to progress quite, quickly with aggressive pathologies.
Interesting. And we have no idea or any speculation about why that's happening. I mean, obviously, if they're younger, they're coming into the clinic
Mm,
earlier,
mm, mm.
but have we seen any differences? Did you hear maybe at the conference anything about where this might be stemming
There's
from?
something about their ovarian function, that is there with breast cancers, and of course, biology is one thing, and then a certain percentage of these younger patients have got hereditary cancers. So again, hence they are picked up early, and the general misconception is, if you're young, you don't get cancers. Okay, so time and again, sometimes when these patients go to the general practitioner, they're sometimes overlooked because they think, oh, cancer is unusual for this group of patients, for this age group, but we have to be vigilant because they are the ones that can have bad biologies and progress in spite of your whatever recent advances you have.
Mm-hmm. So coming to ESMO
Mm.
this year, what are some of the things that you were excited to see, and what were some of the talks or papers that you've come across that you're
There were
most
some
excited about?
groundbreaking talks like the Destiny 05, which would be probably, treatment changing,
Hmm.
management changing
Yeah,
thing.
talk to me a little bit about that.
Yeah. So it's what Destiny 05 is looking at is avoiding chemotherapy in the neoadjuvant setting for HER2 positive breast cancer patients, and I think that will be a huge difference to these younger patients. And the loads of there's HER2 positive breast cancer. In recent times there have been a lot of new drugs, new therapies that come up, but we are we've already seen a trend with ER positive breast cancers that are actually changing as well. There are loads of things that are, I think, big concentration today, or this conference is more about the emerging trends with hormone receptor positive breast cancers, and obviously the triple negative breast cancer, which is, which we still need a lot of improvement. There are some slight improvements and new treatments that come up.
Mm-hmm. When you think about some of these new treatments, my question is always about the ability to implement these treatments in places that maybe have different levels of resources or different levels of coverage. Are there any gaps that you see, or is there anything that you hope that we see as far as accessibility goes and
Yeah,
availability?
it's interesting because in the UK, uh, compared to America, we do have a regulatory body, the NICE. So unless the NICE approves, you don't have access to those drugs. But once you have access, it's uniform access all across the whole country. But it's interesting you say this. There was a trial that people from India have performed because they were looking at lower doses of a drug because it's very expensive, and they found there was no difference. And then the talk was,
Wow.
well, if the company had looked at these lower doses, it might have branded the drug that high is the same cost as the higher dose or the
Mm.
standard dose. Yeah.
That's fascinating. Have you thought about or heard anything about resistance or treatment of resistance? Do you see that often in your practice? And did you hear anything interesting at the conference regarding that?
Yeah, this is the thing. Hormone receptor breast cancer. There is a good talk. Most of the talks are about hormone resistance and what we do. Whether we do doublet therapy, we give two different drugs or three different drugs
Mm-hmm.
to overcome this, and they're targeting at different levels. And then we are having biomarkers. We have specific tests to do those tests and then target these cancers with those specific treatments.
Mm-hmm.
So it's become very targeted, very precise.
Yeah.
Yeah, going back to the Destiny 05, it's not no chemotherapy at all, but less chemotherapy. And so hopefully that will become the standard of practice.
Mm-hmm. Were there any other papers or presentations that you were excited about? I know you talked about the first ones in the beginning, but was there?
There was one thing called positive trial. Okay, it's looking at avoiding or breaking hormone treatment for this younger woman who wants to become pregnant. So, the fact that you have breast cancer or any cancer shouldn't deter you from having normal life, especially if they picked up early. So I have this, it's a difficult conversation with the patients. They had the treatment now and they know, yes, this is never going to recur. Now the reality hits. Okay, I want to have children. What should I do? I'm on hormone treatment for
Mm-hmm.
X number of years. What shall I do?
Mm-hmm.
So actually, there's some evidence to say if you have 2 years and then stop, then you do gain benefit, and then I'll ask them to say, look, go and have your IVF or whatever treatments, or try for a pregnancy naturally, and then an assisted pregnancy, and then come back and restart. So that is what the positive looked at,
Mm-hmm.
and it is really good. I can there's some evidence base for this, and I can quote the figures and say you do need to restart, but it is reassuring that you can go back and try and have good quality of life or have children, which is probably what we wanted, because I think with all this modern life, we women are delaying having children later and later and later. And then when you are in the late 30s or early 40s, and that's when you think, oh, I want to have children, and you hit with this cancer diagnosis, it actually changes your whole world, isn't it? So things, that actually thought, well, the drugs are good, but I think it's about more about a rounded approach, to cancer and treatment, because these patients need uh, to have children. And, that's what the Pulse 2 trial says. Yes, you can interrupt treatment. They can have their treatment, IVF, and it was really positive. Most of them had, whether assisted or natural, they had children, which is really good. So that was, that is, I think for me, is quite interesting.
That's fascinating. There's always conversation about technology, whether it's artificial intelligence, machine learning, developing new drugs, gathering data, looking at past clinical trials being used to collect patient data. What are some of the ways that you are excited about maybe technology integrating further into your work? And do you have any apprehensions?
Well, I'm technically challenged, to say the least. But to be very honest, I think we had a couple of talks just in the afternoon by the radiologist, the surgeon, and a pathologist, and they were talking about how AI actually assists them in their workload and also being very precise. So, it does. I think we have to adopt. And I think somebody gave a statement saying that AI is not going to, take your jobs away. But I think people who wouldn't adopt AI would be gone. The people who would adopt, AI will be here to carry on with the jobs. Yeah.
Right. And I saw you earlier walking and talking with a couple of nurses. Talk to me about some of the ways that you hope to see the health system improve as far as coordination between different members of, the health team. And what are some of the things that you see that are working very well? What are some of the areas that you hope to see, growth in or change in?
In the UK, we have a very good healthcare system. We work as a team. I can't work without my my nurses. My chemo nurses, my CNS team, the specialist nurses do a big job. We do have community palliative care teams who work with his. So I'm part of a I'm part of a team. This is what it is. It's really really wonderful. It's never a one man show. So I have my radiographers. So everybody, we all work as a team, which is really a good model. Uh, there are areas where we don't have enough number of staff. There's always staffing issues and all that, but we all work as a team. It's really good. It's a good model.
When it comes to things like patient support, family involvement in this kind of continuum of care, especially around populations where maybe the topic might be taboo, are there any trends you're seeing, or what do you hope to see kind of change in the ways that families are supporting or that those conversations are being had?
Uh, well, once they start the cancer journey, it's a different story because they have support worker. All the patients have a support worker, and depending upon how busy a certain person is, they do get good support, not only medically, socially, psychologically, financially. The care workers take care of every aspect of that. So the patients do get a lot of support. But I think getting to, utilizing the service, sometimes there are some patients that don't know. A, they don't know. B, they don't want to utilize, and then you have to convince them and say, look, we're all there to help you,
Mm.
to make your journey easy. And then it says, when people would refer to palliative care teams early on in their journey, they had a good quality of life.
Mhm.
So that's what I would keep telling them.
Mm.
And you do convince them, convince patients. And there are a lot of patients who do get convinced because it's lack of knowledge or lack of facilities that they can utilize.
Interesting. So when we talk about research in general, there are a lot of gaps when it comes to who is represented in things like clinical trials and the data that is collected. Talk to me about, from your perspective, are patients talking about clinical trials, or are doctors bringing them up? What are some of the things that you feel like can be done to kind of close that gap of this, these blind spots in the data, especially as we advance with technology? We have these conversations about, there's this insight from machine learning, but then there's like this whole group that is not even represented to, sometimes these things have specific genetic and hereditary
Yeah.
components, like you said. So what are your thoughts on that?
So most of these researchers, when you look at these papers, they also look at the geographic demographics and all that. But having said that, most of the patients, we don't involve them in a conversation saying, look, but we are getting more and more aware of, because the treatments are getting more, niche, and some of the treatments are getting more toxic as well. So we're also looking at patient-reported outcomes in clinical trials. So you're also looking at quality of life, of course, because most of these new drugs, as the cancer treatments progress, it's across the board. The treatments become more targeted. Okay, the people are living longer, but you're treating them like all these clinical trials look at disease-free survival. They are looking at prolonging your survival, not overall survival. Okay, so that means you're not curing them. So these patients are being on treatments longer and longer and longer. So you want to make sure those treatments don't affect their quality of life in a big way, because what you're doing is giving them a quality of life rather than a quantity of life. So, we are there are a few clinical trials that are presented here, which looked at quality of, the patient's quality of life questionnaires, and talk about the side effects and what patients experienced as part of the treatments.
And in your experience, are there any misconceptions or common questions surrounding things like research and clinical trials that might kind of lead people to maybe be apprehensive or question about it? What has been your experience in
No,
communication?
no, sorry to butt
No,
in. So
please.
basically, what happens is most people are, even before I talk about a clinical trial, they want to get involved into a clinical trial. But I keep telling them, like, you have multiple lines of treatment. You can go to clinical trials when it is appropriate. I think it's just the media. I think you talk about a new trial and say, oh, this is life changing, but probably not a life changing in most ways. So most people are very enthusiastic of clinical trials. I haven't. They are a very small percentage who are apprehensive, but I think they do want to try anything
Mm,
or new things.
mm.
So yeah, there is a good enthusiasm.
Good. And what we're seeing a lot is that people are going online more and more to find information, to bring questions to their physicians and things like that. Well, how have you seen that change over the years, and how is that integrating with conversations you're having about care and how decisions are being made, and even how patients understand
Mm,
their
mm.
options?
It's become more complicated because the problem is, in this era, you've got a lot of information. You have to filter that. What information is more appropriate or more authentic to any information? So, there are lots of questions. We do find quite a lot. I do experience a lot of questions that are about, oh, this treatment or that food or this food and all that, which may not apply to them. So it's just so more sometimes, we do direct them to authentic websites and authentic places to have a conversation rather than check whatever is on the internet.
And do you find that patients are generally comprehending or understanding all of this research? I mean, are they looking at peer-reviewed work, or is it mostly articles and social media? And is
Hmm.
there a trend in the understanding of maybe more complex options at all, or have you?
No, I don't think they'll. I don't think they're interested or they know about peer reviews. Forget about patients. They are very intellectual people that I talk to. Are not interested in peer review. They talk about, oh, there's a media. There's something published in a paper and say this is life changing or this is. But you talk about even some of the medical world, they don't talk about peer review. They talk about, oh, this is something that's come up on the paper. Do you think it's going to change
Mhm.
how you treat cancers? So it's kind of, there is a lot of, what to say, uh, projection or negative projection, and that's what you do. It's all about publicity, isn't it? So the more noise you make, the more effect it is, but it may not be the right noise to make.
Mhm. Interesting. What do you hope to see in the future, as far as research, how people interact with patients? What are you excited about?
I think research. This is what everybody is talking about.
Mm,
Is we have, we are exploring every. Uh, Cancer is like a rabbit hole. You close one, another comes off, or the roads. One road is blocked, the other road. So we are looking at all this. Trying to block those roads
mm,
and win over
mm,
cancer. which we are in certain kinds of breast cancer. But what we have to think about is, because we are confident that we are achieving that, we're also looking at what effects these research and the new drugs have on patients, quality of life. I think that is what we are looking in, and this is what the dynamics have changed. We are not talking about new treatments, but also talking about what new treatments are going to, especially when you have two or three different drugs for the same indication. You want to look at what the quality of
Mm.
life problem, effects are.
Interesting. Well, this has been an amazing conversation. Thank you so much for joining us on MD Newsline podcast. It's been a pleasure.
Thank you. Thanks.